We will moderate this meeting, this session with my colleague, Dr. Balaban. And now we are session 6, I think. And topic is spatial session practice guidelines, especially ASL guideline 2025 to 2026. I will be honored to introduce Cynthia Levy. Microphone for you. Thank you.
Can you hear me now?
Yes.
Okay. All right. ASLD guidelines. I have a second disclosure for this because please bear with me. Look, each of the guidelines that we'll be discussing today got its own 20 minutes during the liver meeting, and we have 7 guidelines. So I'm going to go through them, and there will be, thankfully, some repetition because some of the messages are coming along through this meeting very nicely. You will hear me. So this is what we're going to discuss. The non-invasive liver disease assessment, and that one has been discussed several times today. Liver transplantation, chronic hepatitis B guidelines. Then I'm going to just touch on the MASLD task force because that has also been discussed, and we'll finalize with an update or just some preview of what's to come from ASLD. 2025 was really a landmark in terms of the number of documents that we produced because we had 7 guidelines. It was the first time we had the NILDA. Some guidelines, we refresh them, right? We should refresh guidelines ideally every 5 years or so. And those are easier to do, but when you're breaking the ceiling, like doing the first NILDA guidelines or expanding your transplant, that's a lot more work. So we had a lot this year. And please keep in mind, this is really a huge teamwork. I have the honor to serve as the chair for the Practice Guidelines Committee, but I was not the chair during all of these guidelines. We have a big team behind us, a big committee, and they provide oversight and really help us maintain the quality for all the guidelines. I'm very grateful to the writing groups and the chairs. It takes a lot to write one of these guidelines. It can take up to 2 years. Sometimes from the moment we decide to launch the guidelines to when it comes out in a publication for you. It's a lot, many versions of that document. We have for GRADE guidelines, so GRADE is a methodology that we can use to ascertain high quality and evidence base for all our recommendations. There's a special methodology team that does that, and we have to conduct systematic reviews just for the guidelines. And of course, I have an amazing staff behind our team. So starting with the NILDA guidelines, we call them NILDA, non-invasive liver disease assessment, and they came about exactly with this need to try to avoid doing liver biopsies for all our patients. And it's a continuum. We had to divide them in 3 different documents, one for blood-based NILDA, the imaging-based, and then one dedicated only to diagnosis of portal hypertension. I know this is small and I don't expect you to read all of that. There were 6 main questions for the blood-based NILDA, right? We wanted to know, are the blood-based markers accurate in predicting in accurately staging fibrosis for these patients? Is one blood-based test better than the other? Is a combination better than doing one alone? Is a serial, if you do them serially, can you confidently determine if a patient's fibrosis is progressing or regressing? Can we determine the degree of steatosis, and are those good in pediatric populations as well? Those were the questions. The ones that I marked with a red dot, a red bar there, that's when we found out, after all the evidence review, that there is not enough data to confidently answer those questions, and the guideline members answered the best way they could to guide the clinician. it has been stated here multiple times that all of these blood-based biomarkers include components that can be associated with false positives and false negatives, that blood-based NILDAs are better to rule out advanced fibrosis than to rule in advanced fibrosis or cirrhosis, right? This has been beaten to death. And data will be generally lacking for alcohol-related liver disease, at least at the time these were published, cholestatic liver disease, and that's why I highlighted all the data coming up for PSC, and pediatric diseases. You've seen this, I think this is the third time today. Summarizing, when we talk about blood-based NILDAs, there's the proprietary tests like ELF and FibroTest, FibroSure, and then there are non-proprietary, they're easily available like FIB4, APRI, that we can all calculate, right? So ASLD conducted systematic reviews, and we didn't find significant differences between them. So given the cost associated with proprietary tests, ASLD recommended FIB4 as the first test. That's how it all came about. It provided us with thresholds. You all heard that below 1.3, we can rule out advanced fibrosis and patients can be maintained in the community. As we get higher values, either in the indeterminate zone, we need to refer to a specialist. And age affects FIB4, so there are different cutoffs for patients who are older than 65. And in this figure here, we outline how to utilize this test. Again, you have heard this. Below 1.3 for MASLD, you can assume this is F0, F1. Remember, for non-MASLD, and this was originally designed for Hep C and HIV, as was discussed earlier today, the thresholds were a little bit different. Again, because this is evidence-based and systematic reviews were conducted, we had to utilize the intervals and the cutoffs that have been published for those. Nobody created new cutoffs specifically for these guidelines. Okay, so you're very familiar with this already. Then the imaging-based NILDA. So the questions here are along the same lines. Can an imaging-based test help you accurately stage the fibrosis stage for that patient? Is one imaging-based NILDA better than the other, meaning vibration-controlled transient elastography, shear wave elastography, MR-based elastography, is one better than the other or not? Are they better than blood-based NILDA? Is a combination of the imaging-based and the blood-based better than either one alone? We also were very interested in knowing, can we determine fibrosis progression or regression based on imaging-based tests? Can we confidently say that? Is CAP good enough to look at steatosis, and how are we doing with the pediatric population? So same types of questions. And in a nutshell, yes, imaging-based NILDA tests are more accurate than the blood-based. We tend to start with blood because they're cheaper and readily available. Although I learned you have free MRIs. It's not the case for the rest of the world. So we have to use a cost-effective way. Yes, we should combine imaging and blood, ideally serially, but sometimes even at around the same time to better stage our patients, and CAP seems to be accurate. So again, this audience is very familiar with the cutoffs for MRE, more so than the audience in the United States, but reminding people that we have different cutoffs for the fibrosis stage based on VCTE or MR-based elastography. Also, Dr. Turan discussed very well the confounders that we can have for the ultrasound-based elastography. Many of them here. Inflammation. Now we know cholestasis affects our ability in our patients with PBC, for instance. Recent meal, congestion, alcohol use, and obesity can all affect our liver stiffness. Those are the cutoffs that the guideline proposed. So below 8 to exclude advanced fibrosis, and high probability of cirrhosis with VCT greater than, with liver stiffness greater than 15. And you have with MR elastography, this is less affected by obesity. You have the whole liver imaging. So ASLD recommends ultrasound-based elastography or MRE, depending on availability and expertise. And this is how you put it together. I know this is a busy figure. But if you look at it slowly, there is nothing new here. So on top are your blood-based NILDAs with the same cutoffs that we have been discussing over and over today. And oftentimes we do the imaging-based together with this blood-based or sequentially. And ASLD guidelines will provide you with a framework for how to interpret this, but there will be instances where you still need your judgment and you need the shared decision-making with your patients, especially when you have discordant results. For instance, you have in an FOD patient, FIB4 greater than 2.67, but you do a VCTE and the liver stiffness is 11. How do you interpret that? Which one is correct? So you may need to do a liver biopsy, or you may need just to wait and repeat that in a year, as was discussed earlier today, depending on the situation on a case-by-case. For the presence of steatosis, we can use MRI-PDFF. If the fat proportion is greater than 6.4%, that confirms steatotic liver disease, or if the cap is greater than or equal to 275, that was the cutoff utilized for the study, for the guidelines after performing the systematic reviews. But you all know that there are different studies, some use 250, some use 288. This was what the guidelines came up with, somewhat arbitrarily. All right, and then finally the portal hypertension NILDA. This is very well aligned with the Baveno cutoffs, following the rule of 5. So if LSM is below 15 and platelet count greater than 150, you can confidently exclude clinically significant portal hypertension. On the other extreme, if you have liver stiffness greater than 25, you can confirm clinically significant portal hypertension. For the in between 15 to 25, you can use platelet count to help. So if it is below 150 and LSM greater than 20, you can still say there is clinically significant portal hypertension. For the remainder, that's the gray zone. You can use MR elastography to help guide you, or you can use spleen stiffness, as has been discussed in this meeting as well. So summarizing the NILDA guidelines, because again, this has been discussed over and over today, for blood-based, ASLD recommends FIB4 as the initial first-line test, with recommendations to use 1.3 as the cutoff for low risk, no further workup, greater than 2.7 in MASLD indicating high-risk patients. And remember to age adjust your cutoffs for patients who are older than 65. For imaging-based, you can use either one of the available tests. LSM below 8 for the ultrasound-based test excludes significant fibrosis. And in general, the imaging-based NILDAs are much better to diagnose cirrhosis than the blood-based tests. For portal hypertension, we just discussed them. We can easily identify patients with clinically significant portal hypertension and determine if we're going to start a non-selective beta blocker in some of these patients or do an endoscopy. Okay. Let's move to the novelty. So we had 3 guidelines on liver transplantation. It's a continuum. These 3 are in the adult population. We had one for candidate evaluation, one for post-transplant management of graft-related complications, and one for post-transplant management of non-graft complications. There are 2 documents for pediatric management, so candidate evaluation and post-transplant management. They should be released around DDW time. All right, so these documents, all of the 3 of them are long. They have 60 to 90 recommendations, 70 to 90 recommendations. So obviously I cannot go over all of them. I'm gonna try to focus on the ones that are more like paradigm changes or that we felt could be a change. One very important change is the referral timing. So traditionally, we have referred patients for liver transplantation when MELD is greater than 15, but now we are very explicitly saying that MELD should not be the only thing. Even patients with lower MELD, if they have decompensated cirrhosis, they can and should be referred for transplant evaluation. There is a big emphasis on psychosocial assessment and an understanding that especially for alcohol use disorder, our framework has significantly changed. It's a much less punitive approach. We no longer require 6 months of abstinence for these patients, and oftentimes they will be on medical therapy for alcohol use disorder, and that should not be considered a contraindication or in any way prevent their evaluation for transplant. The criteria for liver transplantation for HCC have not changed, but for cholangiocarcinoma, we're seeing more on a case-by-case, but more referrals for intrahepatic cholangiocarcinoma, so this can be considered. Now, frailty and nutrition are considered upfront in this guideline. There is emphasis on preventing and rehabilitation of this patient, so improving the nutritional status and the muscle strength prior to transplant. And finally, in terms of evaluation, ACLF is a strong indication for transplant. Of course, there are some patients for whom liver transplant could be futile, but there are guidelines and algorithms in place to assist us with that differentiation of when this is futile, when this is not, and we should not be shy and not refer patients with ACLF. It's true that they can have high pre-transplant mortality, but they also derive the greatest benefit afterwards. Now, the graft-related complications. This is going to be a busy slide, so I broke it down. First, the surgical and technical aspects of the transplantation. Most of your liver transplants here are living donation, but it's the exact opposite in the United States. And we are giving more and more attention and trying to increase awareness to living donation in the United States because we have similar long-term outcomes. We also recognize the increased rates of complications like biliary and vascular complications, but again, the long-term outcomes are the same. And so we are emphasizing that to expand the donor pool. The use of machine perfusion, both hypothermic and normothermic, has been associated. There's strong evidence that they decrease the early allograft dysfunction and they decrease the biliary complications that we tend to see more with living donation, especially the non-anastomotic strictures, right? So this is strongly recommended for every program doing living donation. Regarding technical complications, the discussion was about early recognition of vascular and biliary complications. The treatment may be either percutaneous or surgical, depending on the timing of the diagnosis, if it's early or late, and the local expertise. For biliary complications, we emphasize that MRCP should be the first line for workup, for evaluation. But if your suspicion is high that there is an anastomotic or non-anastomotic stricture and the MRCP is unrevealing, we still recommend going forward with ERCP, being aggressive there. And consider retransplantation as an option for these patients, in some cases with progressive ischemic biliopathy. As far as immunosuppression, tacrolimus remains the mainstay of immunosuppression. There is strong discussion on early minimization of the tacrolimus or CNI doses to prevent kidney toxicity, so especially in the high risk, the patients who are at high risk for kidney complications, but we are not recommending to withdraw or to stop completely the CNIs, tacrolimus, or swap that altogether for MMF because that is not as strong as tacrolimus. If you do that, patients will have more rejection. We're just recommending to dose reduce these patients, and you can add either mTOR or MMF at lower dose also and keep both to maintain the immunosuppression. There is a long discussion in the guideline about recognition, so diagnosis and management of the various types of rejections, T-cell mediated rejection, antibody-mediated rejection, and plasma cell hepatitis, also, which is a whole different entity. There's also discussion on chronic rejection. The mainstay of treatment and management has not changed for that. And then in the post-transplant recurrent disease, so for viral hepatitis, 2 remarks. One, we know it's safe to treat early for the recurrent hepatitis C, and we're using more Hep C positive donors. So it's safe to treat them in the first 3 months post-transplant. And remember, for the hepatitis B, all recipients should be on lifelong antiviral therapy. The use of IVIG is variable. Recurrent alcohol-related liver disease, the recommendation is that this patient should be under monitoring in the post-transplant period. How to prevent this is still a knowledge gap, and there is research ongoing. For recurrent MASLD, that's another big area. We'll be discussing more in the next guideline. That's the non-graft complication, but it's emphasis on management of all the metabolic complications. And for the autoimmune liver diseases, attention that we may need biopsies. So for PBC and autoimmune hepatitis recurrence, we obviously need liver biopsies. For PSC, that's not necessary. Okay. Moving on to the non-graft complications, the emphasis is on long-term care because the complications now can affect the longevity of the patient, the graft and the patient. For metabolic syndrome, we need to do annual screenings for hypertension, for diabetes, dyslipidemia, and step up and manage those if the primary care physician doesn't feel comfortable, which sometimes happens with our liver patients, right? There was discussion. It wasn't really a recommendation because we don't have enough evidence for that yet, but there was discussion to emphasize early use of the GLP. What's happening here? Early use of the GLP-1 receptor agonist, especially in obese and diabetic patients, and early withdrawal of steroids in patients who are at very high risk for metabolic complications. Cardiovascular and renal, again, lifestyle modification, aspirin use and statin. According to the general population, there is no contraindication to using these medications post-transplant. Obviously, we go back to the issue of lowering FK dose to mitigate the risk of CKD post-transplant. And the guidelines recommend early referral to a nephrologist. Infections and malignancies, there's the beautiful tables. I recommend you download the guideline, beautiful tables and figures on the timing for all the vaccines and how to manage the CMV prophylaxis. Colorectal cancer screening, that's one difference from previous guidelines. And in the general population, we recommend colonoscopy every 10 years. For the post-transplant patients, we're recommending every 5 years. And for patients with PSC, IBD continues to be every 1 year. Strong emphasis on self-management, everything that relates to diet, exercise, mental health, because that will all impact adherence to treatment. Address contraception. Patients who conceive in the first year post-transplant have poorer outcomes compared to those who conceive later on, both in terms of the baby and the mother for rejection. So we recommend to address this early on. Okay, I'm gonna skip this summary. Okay, let's talk about hepatitis B. This guideline was prepared together with IDSA, so the Infectious Disease Society endorsed that together with AASLD. There were 6 questions. So the first one was about prevention of mother-to-child transmission. We have used tenofovir fumarate, right? And we know that's safe, but the question was whether tenofovir alafenamide was as safe as and could be used, and the answer is yes. So it's recommended to start it for mothers with viral load greater than 200,000 at week 28. If IVIG is not available to give to the newborn on day 1, it's also acceptable to start the tenofovir at week 16, so start a little earlier. There is, of course, more data with Viriad than we have with MLD. The goal is to prevent vertical transmission. Then the other question was about prevention of horizontal transmission. Somebody who is surface antigen positive, has low viremia, doesn't really meet criteria for treatment based on the previous guidelines. There is now a recommendation for conditional treatment via shared decision-making. So those are the high-risk scenarios: unprotected sex, persons who inject drugs, household contacts, and healthcare workers with exposure-prone procedures. So nobody should feel uncomfortable to ask for treatment. And there is this process that we call shared decision-making. We are now making it possible for all the patients. The third scenario that is very new in this guideline is the immunotolerant phase. In previous guidelines, we say no treatment needed. Those are patients with more than 10 to the 7th viral load with normal transaminases, remember. Now, again, through shared decision-making, there is a venue to treat these patients if they are older than 40 or they have F2 or greater fibrosis or grade 2 or more inflammation. And even if they don't have this criteria, they don't meet this criteria, but the patient really wants to be treated, then we can treat them under the shared decision-making pathway. Another change for non-cirrhotic Hep E antigen negative patients in the indeterminate phase, again, there's an opportunity to treat. We used to recommend observation only, but now treatment is suggested via shared decision-making. This is with hopes to decrease the rates of hepatocellular carcinoma, which we know is related to viremia. Another big change is about nucleotide discontinuation. So in the past, we provided recommendations that under certain conditions, patients could stop. If you seroconvert the E antigen to negative, E antibody to positive, and viral load is suppressed, you could stop treatment. But now we actually recommend against that because of the higher rates of flares that we were seeing in many patients, about 40% requiring retreatment later on. So we strongly recommend against it. Now, if a patient definitely wants to stop treatment, of course, we're going to honor that, provided that there is no cirrhosis, no co-infection with Delta, no co-infection with HIV. They have been suppressed for more than 2 years, and the quantitative B surface antigen is below 100. So that is a test that we can use. And finally, the sixth recommendation was about expansion of the HCC surveillance protocol. So now, even after loss of hepatitis B surface antigen, we still continue to survey, especially if cirrhosis is present, if they have family history of hepatocellular carcinoma, men older than 40, women older than 50 at the time of clearance. For Delta patients, we should never stop. We should continue to survey them for life. And for HIV, the criteria, if they're males older than 18 and women older than 40, should continue treatment even after clearing the B surface antigen. This is a summary of the main changes. So we can use tenofovir alafenamide. There's a conditional recommendation to treat patients who don't quite meet, the E antigen negative patients who don't meet treatment criteria otherwise. There are recommendations in place to treat immunotolerant patients if they're older than 40 with significant fibrosis or inflammation. We should probably not stop treatment for anybody until there is surface antigen loss, and continue HCC surveillance. Okay, now MASLD was not a true guideline. It was a task force guidance that AASLD put together, and the practice guidelines committee helped to review. You have seen these recommendations today, so very quickly I'm going to go through. This is the main slide of the main takeaway of the MASLD guidelines, which again you have seen 3 times today. Look, this disease affects 1/3 of the world's population. There's no way that us hepatologists can see all the MASLD in the world. So there has to be a system in place to assist the primary care physician and the community doctors to decide who they're going to send to us and who they're going to manage on their own. And this is a step in that direction. It's not perfect. There are limitations to FIB4. There are limitations to elastography. But this is one way for us to provide guidance to our colleagues. So limiting to send the patients with intermediate FIB4 or those who rule in for cirrhosis, despite all the limitations of the test. Patient selection for treatment was also discussed today. Remember, those with stage 2 to 3 fibrosis. And even when you look at the possible treatment ranges that were discussed earlier today, even some patients with liver stiffness from 15 to 20, which otherwise would tell us this could be cirrhosis, but as long as you don't see cirrhosis with clinically significant portal hypertension demonstrated in any other way, they would still qualify for the existing approved therapies. Just keep in mind the exclusions, right? In addition to cirrhosis, active autoimmune hepatitis is a contraindication supposedly to both treatments that are available. Excess alcohol use is a contraindication. Then for resmetirom, active thyroid disease. For semaglutide, a personal history of medullary thyroid cancer or MEN2 pregnancy, those are contraindications. and how you monitor them. This was also addressed today, but repetition is good, so we can all remember. Let's focus on the monitoring. A couple of pearls there. For resmetirom, remember to monitor thyroid and to adjust the statin doses, because resmetirom increases the exposure to the statin that your patient is taking. For semaglutide, we're going to monitor GI symptoms and watch for volume depletion. And for both of them, we'll be serially monitoring their liver tests and the non-invasive test for fibrosis. On the right, you have the assessment of response, which is still, I think, there is still work to be done. They are work in progress, but we want to see 20-25% improvement in liver stiffness and improvement in the transaminases, if not normalization. So here you have the barcodes or the QR codes for these documents, especially the MASL-D, the MASL Pediatrics document, because we didn't discuss today. There was an update to the HCC guideline that you can also access with these QR codes. And okay, what is to come? So this year you're gonna see an ASLD-AGA combined guideline on primary biliary cholangitis, should be ready towards closer to the liver meeting. We are preparing now acute liver failure, so ICU management in acute liver failure and hepatic encephalopathy, but those will come out in 2027. And then the 2 pediatric transplant documents. Also be aware of this new document that our committee is developing. It's called the EXPOs, or Expert Practice Opinions. There will be more concise, expert-based recommendations that will really help you in clinical practice, okay? There will be shorter documents, and we'll release hopefully like 3 or 4 a year of those, so stay tuned. And that's it. Thank you so much.
Thank you, Dr. Levy, for this very well-established marathon, making our life easy. And also thanks for your efforts for our patients. While waiting a question from the stage, I want to ask, since the GLP-1 analogs are much more effective than resmetirom, almost twice more effective, in which patients you are choosing resmetirom rather than GLP-1?
I think we need to be careful with that statement, because this was not a head-to-head study. And while the response rate was twice higher in the semaglutide study, the placebo response was also twice higher. So I think the GLP-1 has other advantages for our patients with metabolic disease, and oftentimes it will be preferred because of the other benefits, cardioprotection, diabetes, a lot of the weight loss, a lot of other benefits that they have. But we cannot say that it had twice the efficacy of resmetirom.
So in which patient you are choosing resmetirom? Is it first-line treatment or?
It's not, yeah. If you ask me, I prefer the GLP in general. But also in the United States, we have issues with what drug is preferred for the insurance, a certain payer. So I may want to prescribe a GLP and insurance will tell me, no, this patient should be on resmetirom, or the opposite. It can happen. I see that for PBC all the time, unfortunately. But I think if they have metabolic disease, my preferred drug is GLP.
Dr. Dertekin?
Thank you for this wonderful talk. I mean, I learned a lot. Just a quick question about the immune-tolerant hepatitis B cases. I mean, I didn't see anything about family history of HCC above 30 years of age. Is there any recommendation for those patients?
Yeah, there was just one. Let me see if can you put my slides back? Just in terms of the surveillance, so patients with family history, we should continue lifelong.
So about treatment or biopsy or non-invasive?
Oh, no, we didn't discuss that.
Okay, thank you.
Sure.
I wonder that what is the ASLD's approach about basiliximab to prevent post-transplant renal protection?
I'm sorry, to prevent?
Post-transplant renal protection, basiliximab.
I'm so sorry.
Renal protection after
Renal
transplant.
Yeah, so the approach is to hopefully within the first 3 months post-transplant to lower the Prograf tacrolimus dose as much as possible and add, usually the first addition is going to be mycophenolate. Sometimes people will do mTORs, so rapamycin instead of the cell-cycle. But first choice is usually the mycophenolate. Does that make sense? So we reduce tacrolimus and we add mycophenolate. We keep both.
Okay. Don't use basiliximab in USA.
Don't use what?
Don't use basiliximab.
Oh, you're talking about induction.
Yes.
Yes, so there was a recommendation, but it was not very strong because the data were controversial. But there, yes, in the guideline, again, there are 70 recommendations. There is a recommendation to use baxilizumab in induction for patients who are at high risk for renal dysfunction. Yes.
Thank you very much. Really excellent presentation. My question is also same thing. Do you prefer to give long-acting tacrolimus, I mean, instead of short-acting, just for prevention kidney? Long-acting tacrolimus. Do you prefer to use?
I think they both have similar efficacy. The guideline did not prefer one or the other, didn't show increased efficacy by one of the two. So either one is acceptable, right? Either the short term or the long term, similar efficacy.
Yeah.
The long term is more expensive. The long duration, once a day, is more expensive in the United States.
Yeah, I have concern about the rejection, especially if the long-acting tacrolimus, if we use the earlier days, we see some patient severe acute rejection. I don't know why. So I have some concern about that. I just want to learn your opinion.
Yes, I can only tell you the guideline doesn't
Okay.
make a distinction.
And then another question, why guidelines say that TDF is more convenient compared to TAF? I mean,
Why is it more?
In pregnant patient, I mean.
Just because there is more data.
Yeah, exactly. Okay.
And
This is
right,
the
there are
just
more
one.
studies published using the TDF than with TAF.
Okay, thank you.
I think Dr. Edelman has a question.
Who has a question?
Thank you very much, Cynthia. This is a just technical question. I mean, the necessary to writing guideline by ASLD, which factors affect that? I mean, the prevalence of the disease in the United States, or how can you guys decide that?
Thank you. That's a great question. So the question is about the process of guideline development, what drives us to pick one topic or another, right? So actually, we solicit topics. So there's a formal process, and every ASLD member who is part of a SIG, the special interest groups, and that's available to everybody, there is a formal process where you just write, I suggest this topic because this and these questions need to be addressed. Or there are new therapies approved, for instance, in PBC, we're gonna do it because there are new therapies and we need to teach people how to use them, right? For hepatitis B, there was a big drive to do it from the patient community because patients want to be treated. And if you know that there's a relationship between viremia and HCC, many patients were uncomfortable saying, I don't meet the criteria that you have for treatment, but I want the drug, right? And so that was a big push, one of the big pushes to redo the hepatitis B, so make the access more universal. But answering your question, we solicit topics from the membership. Then we in the Practice Guidelines Committee will rank them. We review with the journal editors from hepatology and liver transplantation to see, is this topic, are you getting a lot of papers? Is this an interesting topic for our readership? And we review with the governing board. Then we finalize our ranking, and that's how we decide.
I think all the points are very clear. Thank you very much.
Thank you.